Unit 6, National Mental Health Program. 6.1 Introduction. Mental disorders are a significant public health issue and pose a tremendous socio-economic burden on the community. Neuropsychiatric conditions have an aggregate point prevalence of about 10% among adults. About 450 million people are estimated to be suffering from neuropsychiatric conditions worldwide. In 1990, mental and neurological disorders accounted for 10% of the total loss due to all diseases and injuries. This increased to 12% in the year 2000, and an analysis of trends indicates that the burden will further increase to 15% by the year 2020. The resources available to tackle the huge burden of these disorders are insufficient, inequitably distributed, and inefficiently used, leading to a treatment gap of more than 75% in many countries with low and lower middle incomes. In India, the prevalence estimates vary between 5.82% and 7.3%. In terms of the absolute number of people suffering from mental illnesses, the prevalence estimate translates to a staggering 7 crore individuals. The median number of psychiatrists in India is only 0.2 per 100,000 population, compared to a global median of 1.2 per 100,000 population. Similarly, the figures for psychologists, social workers, and nurses working in mental health are 0.03, 0.03, and 0.05 per 100,000 population, respectively, as compared to a global median of 0.60, 0.40, and 2.00 per 100,000 population, respectively. Against an estimated requirement of 11,500 psychiatrists, 17,250 clinical psychologists, 23,000 psychiatric social workers, PSWs, and 3,000 psychiatric nurses, only approximately 3,000 psychiatrists, 500 clinical psychologists, 400 PSWs, and 900 psychiatric nurses are available at present. The estimated figures are calculated using the following norms: 1 psychiatrist per 100,000 population, 1.5 clinical psychologists per 100,000 population, 2 psychiatric social workers per 100,000 population, 1 psychiatric nurse per 10 psychiatric beds. The existing training infrastructure in the country produces approximately 320 psychiatrists, 50 clinical psychologists, 25 PSWs, 185 psychiatric nurses per year. Poor awareness about the symptoms of mental illness, myths, stigma associated with it, lack of knowledge about treatment availability, and the potential benefits of seeking treatment are significant causes of the high treatment gap. Most of the data currently available on the epidemiology could be considered the lowest estimate, representing only the tip of the iceberg, with a large amount of illness remaining undiagnosed or misdiagnosed. Objectives. After studying this unit, you will be able to understand the different types of mental health problems, explain the objectives of the National Mental Health Program, and discuss the National Mental Health Program during the 10th and 11th 5-year plans. 6.2 Types of Mental Health Problems. The various types of mental health problems are discussed below. 1. Severe mental disorders. The prevalence of severe mental disorders has been estimated to be around 2% of the population by different authorities. Severe mental disorders generally include schizophrenia, bipolar disorders, and severe depressions. Depression of any type is now part of common mental disorders, CMDs, and therefore tends to be included under that group. Severe mental disorders should include organic disorders like dementias, which are increasing sharply. Dementia has been estimated to be around 1.36% in the above 65 years age group in a community sample in Delhi. Dementia rates in other parts of the country have varied between 2.7% in urban Chennai, 3.5% in rural Tirupura, and 3.4% in Thiruvananthapuram, Kerala. 2. Common mental disorders. Common mental disorders generally include depressions, anxiety and related disorders, somatic symptoms of psychological origin, and other transient and adjustment disorders. The prevalence in general and primary care settings varies from 20% to 45%. This indicates that patients visiting a general clinic may exhibit CMDs within this range. The prevalence rates in clinic populations do not reveal the true picture. as most individuals do not seek care in primary settings, believing their problems to be emotional in nature. They often rely on methods like prayers, yoga, and meditation to manage psychological problems. 3. Mental retardation. Mental retardation constitutes another major group that has not received the attention it deserves. Rates of mental retardation vary from 0.7 to 29.4 per 1,000 in different studies. Indian studies reported prevalence in children up to 12 years and some up to 16 years. Globally, the prevalence of mental retardation is estimated to be around 1%, while Indian estimates of 2% in children appear to be underestimates. 4. Alcohol and drug abuse. This group is generally missed in psychiatric morbidity surveys of adult populations, as it is difficult to identify in large community surveys. The rates of alcohol and substance use in different populations are as follows. Pondicherry 3.6 per 1,000 for alcoholism, Surya 34.1 per 1,000 for alcohol dependence syndrome, Premrajan et al., Bangalore 2.4 per 1,000, Gopinath, Vellore 4.8 per 1,000 for alcoholism, Agra 1.4 per 1,000 for habitual use of alcohol, Hooghly 13 per 1,000 for alcohol addiction, Chandigarh 23.7% used alcohol regularly. Lucknow, 50% of men above the age of 15 used alcohol in rural areas. Chennai and Tamil Nadu, prevalence rates of 16.75%. Ponnadurai et al., 17%, Chakravarthi, and 33% for men, Matrubutham. A meta-analysis by Reddy and Chandrasekhar revealed prevalence rates for alcoholism around 6.9 per 1,000 for India, with rates among men at 11.9% and for women at 1.7%. The NHS survey revealed the following. Alcohol use 21.4%, 62.5 million people. Cannabis use 3.01%, 8.7 million people. Opiates 0.7%, 2 million people. Any illicit drug use 3.6%, 10.5 million people. Tobacco use is an even bigger problem, with 240 million users in the 15-plus age group. Of these, 195 million are males and 45 million are females. Prescribed drug misuse is estimated to affect 0.3 million people. Alcohol abuse is gradually increasing, with rough estimates indicating that nearly 30% of men are current alcohol users, and nearly 30% of these suffer from dependence. Tobacco abuse is a major health problem in India, with its use gradually increasing due to easy availability and low prices. The rising rates of alcohol and drug abuse present significant mental health challenges. Notably, Kerala has the highest per capita alcohol consumption in the country. 5. Psychiatric problems of children and adolescents, CAMDs. The prevalence rate of psychiatric disorders in children and adolescents worldwide has been estimated to be around 14 to 20%, World Health Report 2000. The problem becomes more complex in low- and middle-income countries like India, where children constitute a large portion of the population. Poor infrastructure for corrected and identifying and managing these problems worsens the situation. Poverty, hunger, malnutrition, and infections exacerbate these issues. Indian studies have provided the following estimates. Bangalore, 12.5% in 0 to 16 years. Kerala, community sample, 9.4% in 8 to 12 years. Chandigarh, 6.3% in school children. ICMR study, Lucknow and Bangalore, 12.8% in 1 to 16 years. Various studies estimate the prevalence rates of CAMDs to be between 6 to 15%. The Mental Health Foundation, UK, estimates that nearly 20% of children require mental health consultations annually, while 10% suffer from a mental health problem at any given time. India's diversity leads to variations, with rates in affluent urban areas resembling those in Western countries, while deprived populations may have different rates. None of these studies have examined backward or tribal areas where rates may differ significantly. Number 6. Suicide. Suicide is a significant mental health indicator of any community. Reported suicide rates vary from 3.9 to 38.6 per 100,000 worldwide. Countries experiencing social crises, such as Hungary and Sri Lanka, have the highest suicide rates, while countries with stability and robust healthcare systems, like the United Kingdom and Israel, report lower rates. However, suicide rate statistics can be unreliable, as social and religious reasons may lead to underreporting. In India, the National Crime Records Bureau (NCRB) provides data for different states and the country, reporting figures around 10 per 100,000. Individual studies have reported the following rates. Jhansi, 29 per 100,000. Rural West Bengal, 43.4 per 100,000. Bangalore, 33 to 35 per 100,000. Suicide statistics in India also reveal a peculiar trend of higher suicide rates among women, especially in younger age groups. Historically, Gujarat reported higher suicide rates among women over 50 years ago. While globally, suicide rates are generally higher among men, this unique trend in Indian women highlights the psychosocial challenges they face. Preventing suicide is a major health priority. Many believe that controlling depression effectively can significantly reduce suicide rates. Additionally, drug and alcohol abuse are strongly associated with suicide. 7. Miscellaneous issues. Women's mental health issues require special attention. These issues are closely linked to reproductive health, encompassing changes during menarche, cyclical changes during the reproductive phase, hormonal changes post-menopause, specific challenges related to pregnancy and childbirth. Psychosocial stress and societal discrimination against girls contribute to unique mental health challenges for women in India. Mental health professionals must address these issues, recognizing that women's health is deeply tied to their social status. Equality enhances their mental health, while discrimination harms it. Disasters, natural or man-made, introduce new mental health challenges. Preparedness to manage such crises can help reduce long-term psychiatric morbidity. It is crucial for state and central governments to maintain ready psychiatric, psychosocial management teams that can be deployed promptly to disaster sites, rather than initiating training only after a disaster occurs. 6.3 National Mental Health Program. Growing awareness regarding the magnitude of mental health problems in the country, coupled with a surge of health activities in the late 1970s, including the Alma-Ata Declaration, the commitment to provide health for all by 2000, and the realization that mental health care was possible through the existing primary health care system, led to the launch of the National Mental Health Programme, NMHP, by the Government of India in 1982. The NMHP had the following objectives at its inception: to ensure the availability and accessibility of minimum mental health care for all in the foreseeable future, particularly for the most vulnerable sections of the population. To encourage mental health knowledge and skills in general healthcare and social development. To promote community participation in mental health service development and stimulate self-help in the community. A model for delivering community-based mental health care at the district level was developed and field-tested in Bellary District, Karnataka, by the National Institute of Mental Health and Neurosciences, NIHANS, Bangalore, starting in 1985. It demonstrated that mental health care delivery was feasible in primary care settings by providing a limited number of psychotropic drugs, training primary care physicians and health personnel to identify and treat common mental disorders through short-term training, offering supervision and support from program officers or psychiatrists, using community-level information, education and communication (IEC) activities and simple record-keeping systems. This model was adapted as the District Mental Health Programme, DMHP, and implemented in 27 districts across 22 states UTs during the 9th five-year plan, beginning in 1996. 6.3 Mental Health Programme during the 10th five-year plan. During the implementation of DMHP components, it became evident that there was an acute shortage of mental health professionals, making it challenging to find trained manpower for DMHP. Additionally, the National Human Rights Commission, NHRC, highlighted the poor state of mental hospitals across the country. In 2003, the program was restructured to address these gaps, transforming from a single-pronged approach to a multi-pronged program for improved outreach and impact. The main strategies during the 10th five-year plan were as follows. 1. Expansion of DMHP to 100 districts nationwide. 2. strengthening and modernization of state-run mental hospitals. 3. Upgradation of psychiatric wings in government general hospitals and medical colleges. 4. Implementation of information, education and communication (IEC) activities. 5. Research and training in mental health. An evaluation of DMHP by NIMS in 2002 found it effective as a community mental health care model. Mental health care became integrated into the general healthcare system, and treatment facilities were made available closer to the community. An additional objective was to decrease the stigma associated with mental illness and institutional care. 6.3.2 Status of NMHP at the end of the 10th five-year plan. The following targets were achieved by the end of the 10th five-year plan. 1. DMHP was implemented in 123 districts across the country. 2. 75 psychiatric wings of medical colleges received support for upgradation. 3. 26 mental hospitals were modernized under the Modernization of Mental Hospitals scheme. Areas of concern or weaknesses identified. 1. Poor availability of skilled manpower in psychiatry and allied specialties impeded recruitment for DMHP. 2. Low awareness of mental illnesses in the community. 3. Stigma attached to mental illnesses and institutional care. 4. Lack of coordination between state departments, e.g. DMHP under the Medical Education Department and the District Health System under the Health Directorate. 5. Lack of community involvement. 6. Non-availability of standardized training manuals or modules. 7. Inadequate focus on issues like suicide prevention, workplace stress management, and school-college counseling at district and sub-district levels. 8. Concentration of trained mental health manpower in urban areas. Issues and challenges identified. Expanding DMHP and enhancing visibility at the grassroots level through intensive IEC activities. Improving mental health manpower training infrastructure. Addressing the manpower gap in psychiatry, particularly under DMHP. Collaborating with NGOs for community-based care of mentally ill individuals. Focusing on preventive and promotive mental health in addition to treating severe mental disorders. Training general practitioners in mental health. Developing standardized training manuals for doctors and healthcare workers. Establishing an effective monitoring, evaluation and implementation mechanism for NMHP. 6.4 National Mental Health Programme during the 11th five-year plan. Taking into consideration the constraints experienced during the implementation of NMHP during the 10th plan period and the lessons learned, the strategies for the 11th five-year plan were developed through a series of consultations with state nodal officers and other stakeholders. It was strongly felt that there was an urgent need to address the acute shortage of mental health manpower in the country. NASH 6.4.1 District Mental Health Programme, DMHP. Accordingly, the strategies for the 11th plan were revised, and the District Mental Health Programme, DMHP, was one of its components. DMHP will be expanded to cover more districts in the country to make community mental health care available to a broader population. Both treatment and promotive mental health care components have been incorporated to make it a comprehensive mental health care program. The technical team at DMHP will include a psychiatrist or trained medical officer, a clinical psychologist or trained psychologist, a psychiatric social worker or trained social worker, a community nurse, and a record keeper. The team will provide secondary-level mental health care at the district level and will also be responsible for training and supervising general health staff in the district to facilitate the delivery of primary-level mental health care through the general health system. The district team will be based at the district hospital. In addition, a two-member team consisting of a program manager and a program assistant will form the managerial team for coordination and implementation of DMHP activities at the district level. This team will be available under the National Rural Health Mission, NRHM, and will implement and monitor NMHP activities at both the district and sub-district levels. A psychiatrist, or in his or her unavailability, a medical officer, will be appointed or recruited as the Programme Officer Mental Health, POMH, for each district. In the case of a medical officer being appointed as the program officer, they would be trained in psychiatry and organizational skills for 4 months at identified institutions. In addition to the existing components of DMHP, which focused on the severely mentally ill, new components like suicide prevention, workplace stress management, adolescent mental health, school and college counselling services, benefiting a larger section of society, will form part of the services provided by DMHP during the 11th five-year plan. Activities under DMHP. The various activities covered under DMHP are: 1. Mental health services, early detection and treatment, identification and treatment of common mental ailments using commonly available drugs will be made available at the Primary Health Centre, PHC, level under the programme. The medical officers will keep a simple record of patients being treated in designated proforma for monthly reporting. The DMHP team will provide supervision and referral support in collaboration with the nearest available psychiatrist. TIE, Life Skills Training and Counselling in Schools. The present education system is achievement-oriented rather than child-centred. It does not address the needs of all children or adolescents who, despite varying levels of scholastic competence, are capable of learning and need to develop abilities or skills necessary to live effectively and cope with adversities. The Life Skills Approach, LSA, promotes empowerment among adolescents. Evidence shows rising rates of adolescent behavioral problems and suicides, including crime, violence, sexual permissiveness, drug abuse, academic competition, and school dropout. Life Skills Education, LS, can be used as a base for various health promotional activities, such as the prevention of tobacco or drug use, teenage pregnancy, and dealing with violence. Life skills to be taught at the school level, especially to adolescents, include critical and creative thinking, decision-making, problem-solving, communication skills, interpersonal relationships, coping with emotions and stress, and self-awareness and empathy. Life skills training would be imparted through master trainers and identified school teachers using manuals or modules prepared for this purpose. Additional resources will be provided to address stress during exam periods so that children are better equipped to cope. DIE, Counselling Services in Colleges. A significant proportion of college students have recognizable mental disorders, such as depression, anxiety, somatoform disorders, adjustment disorders, personality disorders, and alcohol or drug abuse. Many more may suffer from subclinical symptoms and emotional disturbances, contributing to observable behavioral abnormalities, including aggression, ragging, hostility, hopelessness, severe examination fear, conduct problems like lying, stealing, running away from home, criminal activity, sexual promiscuity, alcohol and substance abuse and addictions, absenteeism, irregular attendance, dropping out from courses, poor performance or failure in examinations, medically unexplained somatic symptoms, frequent sickness and accident proneness, suicidal attempts. These issues will be addressed by training existing counsellors or teachers in colleges to equip them with skills for early identification and management of these problems through counselling and appropriate referral. IV, Workplace Stress Management. The modern work environment generates significant stress due to high expectations, poor time management, and a target-oriented approach. High stress levels are found among both top-level executives and low-level workers. Workshops for stress management will be conducted at identified workplaces by the DMHP team or NGO voluntary organisation partners using standardised training manuals. V. Suicide Prevention Services. The demanding atmosphere, pressure to perform better, and struggles for survival in adverse circumstances contribute to an increased tendency towards suicide. Timely management of such situations can prevent many suicides and save precious lives. District counselling and crisis centres, established in collaboration with NGOs or other identified partners, will provide help through helplines or counselling services. Role of NGOs or governmental organisation partners. NGOs will be involved in implementing various activities of DMHP. 2. Training. All the medical officers and health staff of the district will be trained to provide basic mental health care at the community level. Support and referral services will be available in the form of a program officer or psychiatrist at the district level. Grassroots level health workers will be trained for the early identification of mental illness and appropriate referral. 3. IEC activities. There will be extensive information, education and communication (IEC) activities as part of Behavior Change Communication (BCC) to raise awareness about the signs and symptoms of mental illness and the availability of services under DMHP. Specific BCC strategies will be developed based on the needs of the district in consultation with the district IEC officer and other program partners. Non-governmental organizations, NGOs, or governmental organizations, GO, will play a primary role in organizing IEC activities. TASH 6.4.2 Manpower Development Schemes in Mental Health. The shortage of qualified mental health professionals was a major constraint in the effective implementation of NMHP during the 10th five-year plan. In the 11th plan, significant emphasis has been placed on addressing the shortage of mental health manpower in the country. These schemes aim to increase postgraduate training capacity in the mental health specialties of psychiatry, clinical psychology, psychiatric social work, and psychiatric nursing. The postgraduate courses identified for support under the scheme include MD, DPM, DMB in psychiatry, MPhil in clinical psychology, psychiatric social work (PSW), and psychiatric nursing. The following schemes are under implementation to address manpower concerns in mental health. 1. Centers of Excellence in Mental Health, Scheme A. This scheme aims to establish centers of excellence in the field of mental health by upgrading and strengthening identified existing mental health hospitals, institutes. The objective is to address the acute manpower gap and provide state-of-the-art mental health care facilities. These institutes will focus on producing quality manpower in mental health to meet the needs of NMHP. Budgetary support under the scheme is up to 30 crore per centre. It is planned to establish at least 11 centres of excellence in mental health during the current plan period. This initiative will result in an annual increase of at least 44 postgraduate seats in psychiatry, 176 MPhil seats in clinical psychology and psychiatric social work each, and 220 seats in diploma in psychiatric nursing. Once established, these centres will produce a total of 616 qualified mental health professionals annually. 2. Scheme for Manpower Development in Mental Health, Scheme B. This scheme aims to develop postgraduate training capacity in mental health institutes and medical colleges. It is more cost-effective and will cover a larger number of institutes compared to Scheme A. Under this scheme, government medical colleges, government general hospitals, and state-run mental health institutes will be supported to start postgraduate courses or increase intake capacity for training in mental health specialties. Support will be provided to set up or strengthen 30 units of psychiatry, 30 departments of clinical psychology, 30 departments of psychiatric social work, and 30 departments of psychiatric nursing during the 11th plan period. This scheme is expected to generate annually 60 psychiatrists, 240 clinical psychologists, 240 psychiatric social workers, and 600 psychiatric nurses. Manpower development schemes, Scheme A and B, are designed to address the long-term need for trained mental health professionals. In the short to medium term, the existing shortage of manpower will be managed by training medical and paramedical professionals to support NMHP effectively. 3. Information, Education and Communication, IEC. An intensive IEC campaign, using innovative strategies involving mass media at the central or regional level, is essential to reduce the stigma attached to mental illness and increase awareness of available treatment and mental health care facilities. This would lead to increased utilization of services under NMHP. Increased awareness of the provisions of the Mental Health Act 1987 is also necessary for its effective implementation. 4. Research and Training. While basic and clinical research in mental health, psychiatry and allied disciplines is being conducted in educational and research institutes, there is a significant gap in operational and applied research in mental health. This issue will be addressed by providing funding support and encouraging existing institutes to prioritize mental health research. 5. Non-governmental organization, NGO, or public-private partnership, PPP schemes. The burden of mental disorders is immense. and government efforts must be supplemented by NGOs and voluntary organizations working in this field. Many of these organizations require financial support to scale up their activities. Mental health services for community-based rehabilitation, homeless mentally ill individuals, ambulatory services, geriatric populations, out-of-school adolescents, slum dwellers, and other vulnerable groups not covered under DMHP would be implemented through credible NGO partners. Additionally, innovative pilot schemes involving NGOs or public-private partnerships, PPPs, would be funded to ensure the availability of basic mental health services at the grassroots level. 6. State and central teams. Dedicated manpower is required at the central and state government levels for the effective implementation, close monitoring, supervision, and periodic evaluation of NMHP components. 7. Support for state mental health authorities, SMHAs. As per the Mental Health Act 1987, state mental health authorities are responsible for the development, regulation, and coordination of mental health services in the states and union territories. SMHAs are also tasked with the implementation of the Mental Health Act 1987. However, many SMHAs are unable to fulfill their statutory responsibilities due to a lack of funds. To address this, financial support will be provided to SMHAs to enable them to perform their routine functions, which would lead to an overall improvement in mental health services at the state level. 6.5. Let us sum up. Considering the burden of mental health disorders in the country, the Government of India implemented the National Mental Health Programme, NMHP, in 1982. However, due to insufficient funds, the programme could not be effectively implemented. A real breakthrough was made during the 9th Five-Year Plan, 1998, when the District Mental Health Programme, DMHP, was introduced in 27 districts under NMHP. This community mental health model of care was developed based on the mental health scenario in the country. Recognizing the need to support psychiatric wings of medical colleges or general hospitals, modernise mental hospitals, many of which were established during the British era, and strengthen IEC and research activities, additional components were added, and NMHP was re-strategized. However, the programme could not achieve significant success due to an acute shortage of mental health manpower in the country. The stigma attached to mental illness further prevents optimal utilisation of the limited mental health services available in the country. To address these challenges, the government took steps to integrate mental health services into the general healthcare delivery system through the implementation of DMHP. Additional components, such as school mental health, college counselling, suicide prevention, and workplace stress management, have been included in DMHP to meet the community's mental health needs. The Mental Health Act was enacted in 1987 to address issues related to the admission, discharge, treatment, human rights, and guardianship of mentally ill individuals. Over time, the programme has evolved to reflect the changing mental health landscape in the country. 6.6 Glossary Behaviour Change Communication, Central Mental Health Authority, TM Common Mental Disorder, D Disability Adjusted Life Year, District Mental Health Programme, DNB Diploma of National Board, DPM Diploma in Psychological Medicine, DPN Diploma in Psychiatric Nursing, GO Government Organisation, Indian Council of Medical Research, IEC Information, Education and Communication, Life Skills Approach, Life Skills Education, MHA Mental Health Act, National Mental Health Programme, NGO Non-Governmental Organisations, NHRC National Human Rights Commission, NIMS National Institute of Mental Health and Neurosciences Bangalore, PG Postgraduate, Primary Health Centre, PPP Public-Private Partnership, Programme Officer Mental Health, Psychiatric Social Worker State Mental Health Authority, Severe Mental Disorder, VO Voluntary Organisation, 10th Plan 2002 10th Five-Year Plan, 11th Plan 2007 to 12, 11th Five-Year Plan, UG Undergraduate Union Territory,